Okay, so short lecture on pediatrics, a little bit of everything here. Starting with colic. There's a short YouTube link here that I will post to your Blackboard that goes over. You can search on YouTube colic and have a lot of informative videos. This may be a little hard to see on the slides, but the main thing is the definition of colic is normally a well-fed, healthy baby. But for some reason, it is crying more than 3 hours a day, 3 days a week, for 3 weeks or longer. Nothing that you do helps the baby. Episodes seem to be long and unrelievable. The cause of colic is actually unknown. Symptoms is crying. They're inconsolable, but there's a normal stool pattern. If there's abnormal stool pattern, you may look into other causes of something else going on. Test and diagnosis is done by a physical exam. Treatment would be soothing techniques. Teach your parents how to soothe your babies and support the parents. So teach them that it's never okay to shake or hurt their baby. Crying is the #1 cause of shaken baby syndrome. So make sure parents know it's okay to walk away if they need to. Child abuse, there's a whole separate play pause it on child abuse. Just know that it is mandated that we report suspected child abuse. Failure to thrive. So the definition is inadequate growth from inability to obtain or use calories required for growth. So it's if the child plots less than the 5th percentile on a growth chart. There's organic causes and non-organic causes. So organic cause is an underlying problem, such as like a health issue. Non-organic would be from abuse, neglect, poverty, or stressful situations. So in the definition, inadequate growth from inability to obtain calories required for growth would be non-organic. So abuse, they can't obtain the calories, they don't get the food that they need or the nutrition that they need. Inadequate growth from inability to use calories required for growth would be an organic cause, so an underlying health issue. Signs and symptoms are listed in your ATI book. The child will look malnourished and growth and development will be delayed. Treatment will be nutrition-based, high-calorie, observed for their growth and development and their interactions. Poison prevention, we're going to focus on lead poison. Just know that prevention is key, so education for parents to keep their medications locked up, their cabinets locked, their laundry detergent without where it's not within reach. Poison can be accidental, or it can actually be a form of abuse or self-injury. This is actually a link to a forensic file episode where they thought that the child accidentally ingested lead and it was actually intentional, and they ended up arresting someone for murder. Prevention, prevention, prevention. Lead poisoning, low exposure, the child can be easily distracted, impulsive, hyperactive, maybe mild intellectual difficulty, and some hearing impairment. But it could be confused for just childhood behavior, hyperactive, easily distracted. High exposure, cognitive delays, blindness, paralysis, coma, seizures, death. Sometimes it's hard to tell, especially in young children, so we do routine lead levels at 1, 2, and 3 years of age just to detect lead poisoning. Levels in between 1 and 5 are okay. Above 5 is considered abnormal. Obviously, you want to remove the exposure to the lead and make appropriate referrals as needed. Here's the poison helpline. Make sure all parents have access to this. And when they call, make sure they have the information that the poison helpline is going to want, which is listed here on the slides. Iron is a medication that a lot of people, or vitamins, that a lot of parents don't think of keeping out of reach of their children, where a child can actually die from iron poisoning. So, even vitamins and your supplements, make sure they're out of reach. Ears, we highlight the differences in between pediatrics and your adult patients. Pediatrics have more ear problems than adults because of their eustachian tube. It's more horizontal, it's shorter, and it's wider. So when the baby eats, yawns, hiccups, that opens and allows things to transfer into that middle ear. External ear canal is small and the middle and inner ear are large, so the tympanic membrane is closer to the surface and can be easily injured. Babies can hear in utero starting at 20 weeks gestation. That's why the hearing screen post-birth is considered accurate. Acute otitis media is an infection of the middle ear, and otitis media with effusion is the collection of fluid in the middle ear, no infection. And it's related to the eustachian tube. Signs and symptoms of the acute otitis media or the infection would be rubbing and pulling, crying, lethargic, bulging yellow or red tympanic membrane, and then your signs of your infection: swollen lymph nodes, fever, drainage. Your effusion signs and symptoms, so the fluid in the ear, fullness in the ear, balance disturbances, hearing loss, and the color is going to be orange upon assessment. Treatment: pain control. This is going to be your Tylenol, your ibuprofen alternations, and then ear drops. So remember, less than 3 years of age, ear drops, you want to pull the pinna down and back. Greater than 3 years of age, you pull it up and back. Keep the child upright, so the positioning is important. And antibiotics, they're going to wait for 72 hours for it to clear on its own before prescribing those. If none of this helps or it's reoccurring, they may place tubes in the ears. It's an outpatient procedure, only lasts about 15 minutes. Can cause some mild pain. The tubes will come out spontaneously on their own in 6 to 12 months. Education for the parents after tube placement. Limit activities for a few days. Notify provider when the tubes come out. Avoid getting water in the ears, so cotton balls during bath time. Feed the child in an upright position. Avoid infections, get immunizations to help avoid these infections. Avoid secondhand smoke. Eyes. So visual acuity is not very good at birth. It's 2400. So your normal adult is 20/20. So the infant can see at 20 feet, what the adult can see at 400 feet. It goes to 20/50 at 3 years of age and gets to 20/20 by 6 to 7 years of age. They can't distinguish color as well, or near and far sight as well. Binocular vision is decreased, so babies' eyes will cross. They're at more increased risk for injury. Their sclera of their eyeball is thin and translucent, which gives their eyes the bluish color for the first 6 to 12 months. And their tears drain into their nasal cavity, so that's why babies will not produce tears. Alignment and movement coordination should be obtained by 3 months of age. Conjunctivitis, redness, pus coming out of the eye, crusting. The baby rubbing their eye frequently can be caused from viral, bacterial, or allergic reactions. It's spread by direct contact, so standard precautions is to be used. Viral will clear on its own in 7 to 14 days. Bacterial will spread and clears with antibiotics. If it's allergic, allergy meds will be recommended. Skin, so pediatric skin. An infant's skin is thin, so this makes it more difficult for them to regulate body temperature. They lose heat rapidly and become easily chilled. There's increased absorption of harmful chemicals too because of that thin skin. It contains more water and loosely attached cells, so they're more at risk for bacterial infections. And there's less melanin at birth, so they're lighter in color. So think of your babies of a different race. When they're born, they say, oh, but they look so light. It's because there's less melanin. Contact and atopic dermatitis is covered in Sam's Play Posit. And there's also notes at the bottom of your slides that you can print out. The main difference is your contact dermatitis is caused from something that you can remove, such as a diaper. The atopic is something that will reoccur. It could be allergy related, and they may be put on topical corticosteroids. Acne, most common in your adolescent population, from puberty and hormonal fluctuations. It can affect self-image, so you want to make sure you monitor that. Diet high in grease, so even if they're just around grease or eat a lot of grease, it can increase their acne outbreaks. Accutane is the main medicine I want you to be familiar with. Know that it can cause mood changes and suicidal ideation. There's a Dateline episode you can Google about someone murdering their dermatologist because they prescribed them Accutane. It can also be very teratogenic, so if a female is prescribed Accutane, you want to make sure that they're on some form of birth control. Acne can also lead to cellulitis, so if someone's picking their acne, it can become infected and lead to cellulitis. Burns, I know you all have not covered burns in your adult patients yet, so the main difference I want to point out is how they measure total body surface area. Because the child's body is proportioned differently, such as the head, a child's head, if it's burnt, it's considered 18% of their total body surface area burned, whereas the head of the adult's only considered 9%. Same with legs, are different for your adult and your child. ATI has some good percentages, pictures. If it's less than 10%, it's going to be an outpatient basis, 10 to 20% treatment done at the hospital, preferably a burn center, and then greater than 20% would be admission to a burn center. Treatments listed here, obviously remove the source, keep clean, prevent infection. Major burns, airway, so you want to make sure that your patient can breathe. That's your main thing with your major burns. I don't expect you to know your fluid replacement for burns at this point. Monitor for infection, but airway is the most important. Wound care, pre-medicate. This can be very painful. This is going to be your morphine and your Versed, not your Tylenol. And prevent infections. This can be, their dressing changes can be very, very long process. All right, kids' immune systems versus the adult. IgG is the only immunoglobulin that crosses the placenta. IgM is low at birth and increases on week 1 until it reaches its full amount at 1 year of age. IgE and IgA are not present at birth. They increase about 2 weeks of age, and normal values are not reached until 6 to 7 years of age. These things are the reason why kids less than 6 years old become ill so often. If an infant is breastfed, these immunoglobulins, you know what I'm trying to say, cross into the breast milk and provide great prevention of infection. HIV is the immune system that we're going to talk about in kids, the immune problems. These are from your med-surg class, the same slides as your adult med-surg HIV. I'm just going to point out the differences. Here in red it says perinatal exposure or through breast milk. So if a child is diagnosed with HIV, it most likely came from exposure from the mother. So this is where we go through all these slides and we talk about prevention and education. We're going to educate our sexually active females so they don't transfer it to their babies. Diagnosis: if the child is greater than 18 months of age, it's going to be a positive ELISA and a Western blot. And if they're less than 18 months of age, it's going to be a PCR and a virus culture. So we don't do the rapid screening with these young kiddos because it's very costly and they're not going to have any prevention measures as far as safe sex practices that we educate our adults with. Your diagnosis and your disease progression in response to therapy is slightly different for children. So the big cutoff, it's on page 435 in your ATI. Your big cutoff for your adults from HIV to AIDS is 200, where you look at your infants level on the chart in ATI and it's 750. So your CD4 count differences in your infants and your older children. Here it says they may be asymptomatic, so your adolescents may be asymptomatic, but think about your infants and their immune system. they could actually display symptoms earlier the younger that they are. And here again talks about your normal progression for your adult, and we talked about the difference in CD4 counts dependent upon age. We treat in pregnancy, we treat moms to try to prevent the spread to babies, and then we automatically treat babies after birth if they're born to an infected mother. Therapy is expensive, there's severe side effects, compliance is essential, it can be dangerous if they stop taking them, and it can cause drug resistance. Prevention, prevention, prevention. Protect yourself from all patients. Use standard precautions to help prevent the spread from needle stick injuries or even during a birth. That's it.